Good evening, friends. So, meeting you after almost 2 to 3 weeks. Our 225th webinar, Approach to a Case of Edema. Edema is one of the common symptoms or signs which we can see in children. It is critical, then likely involves the kidney. If it is generalized, middle-aged and the elderly. Some edema is to be treated, some edema is not to be treated. So edema is defined as an increase in extravascular component of extracellular fluid volume. So just understand, for us adults, 45 to 55% body weight is fluid. Blood, plasma, intracellular fluid, and extracellular fluid. Edema could be localized. Edema could be generalized. This is the biggest tip for us. When you're looking at both the feet edema and you see that one foot is normal, one foot or one leg is edematous, or even in both, one leg is swollen quite a bit and other is 50% of that. That edema is 99% due to a local cause and not a systemic disease. Because liver is one, heart is one, kidneys are two, but they work as one unit. Anything related to liver, kidney, or heart, that edema will be bilateral. Let's understand how edema forms. 1/3 of total body water is in extracellular space. This is the 1/3. In this extracellular space, we have 20% plasma, which is intravascular. Extracellular is outside the cells. So plasma is in the vessels and 80% is in the interstitial space, the space between cells. That is 80%. So this is the vessel and this is extravascular. Now what happens from here? We have various ions and fluid keep going from intravascular to extravascular compartment because of colloid oncotic pressure. The cells retain a shape because of hydrostatic pressure, tissue tension. So at the arterial end of circulation, microcirculation, to the venous end of microcirculation, from vascular, water and diffusible solutes, they come into vascular from arterial to venous end. And in this process, increase in the pressure in the vessels of microcirculation because of venous obstruction. If your veins are obstructed, the backflow affects the microcirculation. That may lead to edema. Because of hypoalbuminemia, low albumin, colloid oncotic pressure may reduce. So that's why edema is one of the feature of low albumin. Damage to capillary endothelium increases the permeability. The capillary endothelium can get damaged either by chemicals, bacterial, thermal, or mechanical agents. And due to an allergy, hypersensitive phenomena, the capillary permeability can increase. So even in allergy, you get edema localized. And where there is anaphylaxis, you get generalized edema or maybe angioneurotic edema. Subtle edema, many times we write mild edema. Please stop using that term. First sign is the patient says, I cannot remove my finger, I cannot remove my ring. Ladies will say, my blouse is tight on some days. Slippers leaving behind impressions. Socks, the top of the sock which has the elastic leaving a depression. Stethoscope leaving behind ring mark on chest. This shows generalized edema even on the chest. This is very common in nephrotic syndrome. Gross edema, periorbital. It starts from dependent parts, the lower limbs. When it worsens, it comes up. It may affect the scrotum, ascites, pleural effusion, and then periorbital. It should be pitting. Non-pitting edema is either myxedema or elephantiasis. The volume of interstitial space may increase by several liters before edema is noted. So, the very fact you can see edema, even if the pitting is barely 2 millimeter, please don't call it mild edema, little or mild edema. See this. The people will tell you, in the evening my feet are swollen, and they come to you in the morning. You teach them how to press with a finger or a thumb. Tell them early morning on waking up and just before bedtime, take a picture and share it with you. So the subjective sensation of there is swelling is confirmed by this depression. What are the common causes? Systemic, local obstruction of venous return, deep vein thrombosis, varicose veins. There's no obstruction there, but the veins have become engorged. The blood is filled in the veins. It does not go back to the heart. Cardiogenic, as I said, heart. Nephrotic syndrome, cirrhosis of liver. Peripheral venous insufficiency or obstruction, as I said, varicose veins or DVT. What is the mechanism? Volume overload. In heart, because the heart cannot pump properly, there is backflow of blood that causes volume overload on the systemic circulation, leading to edema. obstruction to venous flow, deep vein thrombosis, or clots in the saphenous vein, iliac vein, or varicose veins where there may be no obstruction, but the veins are so engorged that the blood is pooling there. Check whether localized or generalized. I told you first thing should be localized or generalized. Localized, limb, one lower limb or both, is likely to be venous lymphatic obstruction. So elderly patients, non-hypertensive, non-diabetic, blood pressure normal, no RALs, no signs of failure, liver fine, look for varicose veins. Look for any free fluid in the abdomen. For male patients, check scrotum for any edema, not hydrocele, edema. And check whether chest wall is edematous. I'm not talking of pleural effusion. I'm talking of edematous chest and abdominal wall. Face, likely proteins, more in the morning, very likely cause of renal. Myxedema, due to very bad hypothyroidism. Allergy, NSAID allergy, localized edema on face, right upper eyelid swollen, no pain, is likely a bite. Generalized edema, first ask about urine output. Generalized edema of short duration, suspect acute renal failure and rule out first. If the patient says oliguria despite good water intake, rule out acute renal failure. Oliguria with ingestion of usual amount of water, net accumulation of water will give you generalized edema. Non-inflammatory, inflammatory edema is because of trauma, because of allergy. Generalized edema of great degree, very severe. You put your finger or thumb for 5 seconds, there is almost a 2 millimeter or 3 millimeter depression. Cardiac, hepatic, renal. So within first 2-3 minutes, you have distinguished whether it is systemic or it is local. Then nutritional. Nowadays, we see nutritional very rarely, where severe protein calorie malnutrition, we generally don't get such cases nowadays. Edema originating from inflammation, hypersensitivity, as I told you, trauma. You have a patient who has edema on right ankle. You ask the patient, any pain? Yes. Did you sprain? I don't know. But if there is pain, there is inflammation, and swelling is a part of inflammation. Edema of cirrhosis occurs in late stages. Because when a patient gets cirrhosis, the liver is contracted, portal circulation is compromised, and then blood cannot flow. The blood flows backwards. It causes esophageal varices, which causes ascites. It may cause pleural effusion. Heart failure edema, first in lower limbs in patients who are walking around, and bedridden patients, you have to turn the patient and check the sacrum because gravity. So if the patient is a known diabetic, ask for any last 2D echo done. You will see the ejection fraction is not normal 55 to 65. Edema occurs due to elevated right atrial pressure. Right heart failure is more common to give edema than left heart failure. Other cardiogenic causes, pericardial disease. I just had a patient, young patient, 24-year, kept complaining of chest pain. We did a ECG, although there was no signs of any cardiac thing, but we still did to rule out because you are seeing young deaths today. We did an X-ray. The lab said clear. They were looking for pneumonia. When the film came, we could see that there is some amount of pericardial effusion. He is from a socio-economically backward class, referred to Sion Hospital. They detected HIV. So pericardial effusion, common cause tuberculosis and HIV. Right-sided valve lesion, tricuspid stenosis. Nowadays, everybody uses 2D echo to diagnose valvular disease. You hear a murmur, immediately send for 2D echo. Cor pulmonale right heart failure in a respiratory problem. COPD giving rise to cor pulmonale right heart failure. Nephrotic syndrome is when kidneys are allowing to excrete very large amount of protein. If you do a 24-hour urine protein, the albumin will be above 3 grams. Initially, it is seen in areas of low tissue pressure, which will be scrotum. Periorbitally, then it goes to feet, then it goes to all over. Why periorbitally? If you can just pull out the skin below the eyes, there is a potential space. Scrotum has a potential space. So these are the places that fill up first in case of nephrotic syndrome. Most likely due to sodium retention from renal disease. Albumin low, sodium retention, and not from arterial underfilling. This edema is not due to arterial underfilling. Which edema is potentially fatal? Puffiness of face in a child. A child with fever, even mild, but puffiness of face. You have to ask the parents, is the child always like this? If they say yes, tell them to show you an old picture. Don't believe yes just like that. Do a urgent urine test. If you don't have facility, collect the urine, and if it is smoky urine, that is acute glomerulonephritis unless proved otherwise. Tender edema of acute onset in lower limb. Especially one lower limb, either DVT, deep vein thrombosis, or some arterial thrombus. Pulmonary edema. You can hear the rals from 10 feet away. The treatment is keep giving Lasix till you shift to the hospital. Eclampsia. Patient in last trimester of pregnancy, known case of hypertension. Now the BP is high. And if you ask, last few urine tests have been albumin plus, patient may be in altered sensorium. This patient can die, the baby can die. Angioneurotic edema, likely due to NSAID abuse or even honeybee bite. Treatment, which is chronic, you have to reduce salt. Because wherever salt goes, water goes. I have explained this experiment once before. Take two plates, cut a tomato into two, put half each in each plate. In one plate, you put salt. After 10-15 minutes, the plate where you put salt, you'll see much more water than the other plate. So the dictum is wherever salt goes, water goes. Ensure plenty of movement to increase circulation if it is not a systemic edema. Frequently raise the affected area of the body so that it is above the level of the heart and use gravity to reduce the edema. Consider bandages or compression socks in case of varicose veins to keep pressure on the edema. Do we need to treat all edema with diuretics? The answer is no. Because diuretics come with their own problems. Treatment of the cause. You have to diagnose the cause. Nowadays, we see prescription of many doctors in a 25-30-year-old patient with slight edema feet. They have given Ditor, which is criminal. Proximal tubule diuretics, Diamox, which we generally use only for cerebral edema. Phosphodiesterase inhibitor theophylline, again respiratory. We don't use for pedal edema. Loop diuretics, our furosemide and torsemide. Lasix or Ditor, we are using Ditor more now because of the electrolyte problems of furosemide. Distal convoluted tubule diuretics, chlorthalidone, again used very commonly nowadays with hypertension. So you have telmisartan chlorthalidone combination, aquazide, hydrochlorothiazide, and indapamide. These are all diuretics which may be used without edema but to control blood pressure. Because blood pressure will be controlled if your volume is less. And cortical convoluted tubule diuretics are aldactone. Aldactone is largely used in hepatic edema, not for other edemas. And amiloride, trimethoprim, we generally don't use much, sodium channel blockers. The dosage depends on half-life. Torsemide, whatever quantity you give, 80 to 100% absorption, half-life 3 to 4 hours. Furosemide, 50% absorption, half-life 1 to 4 hours. So giving the same dose in two divided doses gives better diuresis than one single dose. So the best time is you're giving Ditor plus half in the morning at 8 o'clock, half at 4 o'clock. That will give round the clock diuresis. Beware of loop diuretics. The effect of loop diuretic dissipates rapidly, especially furosemide, after which kidneys immediately begin to reabsorb sodium and the diuretic effect is nullified. Process being called post-diuretic sodium chloride retention. So what you have achieved, sodium excretion, now has bounced back to post-diuretic sodium chloride retention. This compensates entirely for the sodium loss and you achieved nothing. Sodium restriction is more important than giving diuretic. Specific scenarios, treatment with ACE inhibitor or angiotensin receptor blocker should be considered in patients with calcium channel blocker induced edema. So amlodipine gives peripheral edema, but S-amlodipine does not give that much peripheral edema. If the patient is complaining of gross peripheral edema with amlodipine and constipation, you shift to ACE inhibitor or ARB. Spironolactone, aldactone should be used to decrease morbidity and mortality in patients with heart failure, NYHA 3 or 4, who are symptomatics at minimal activity or at rest. Ascites. By the time ascites has occurred, it's futile to think that diuretics are going to work because liver is already damaged. You have to remove water. And that water, unless you are treating the liver or the cause of cirrhosis, is going to collect again, and you may have to get it removed once again. Spironolactone alone or with furosemide should be used in patients with cirrhosis and grade 2 or 3 ascites, because one of the complications of ascites is hyperaldosteronism. So you cannot use plain furosemide, you have to use with spironolactone. Long journey. People who travel Bombay to US, Bombay to London, who travel by bus to Bangalore, even if they are young. Today, nobody is young. Tell them to keep moving the feet. As you know, tap music, that causes the calf muscles to act as a pump and push the venous blood upwards. More than, I would say, even 4 or 5 hour journey, even if I go to Pune, even in the car, I am doing tap music. I keep some music on and I keep doing tapping. When does treatment fail? Patients may be taking diuretics, but salt is going in. So, as a practicing physician, when you say reduce salt, you have to caution them about hidden salt. No, doctor, I don't take salt at all. My food is made fika. What about pickle? Yes, I take one piece of pickle every day. Pickles, chutneys, papad, farsan, chips. These are all very high salt content. Not adherence to medication. No, because I go from Thana to Kolaba and then I get urination in between, so I don't take. Then when I reach office, I take. But if I have meetings, I don't take. Then again, treatment fails. Altered intestinal absorption of loop diuretic. Patient has irritable bowel syndrome, getting motions very frequently. Decreased renal perfusion caused by low volume arterial disease or drug use, ACE inhibitor or NSAIDs. NSAIDs will cause edema. Pharmacokinetic causes drug diuretic half-life to get reduced, and reduced tubular secretion caused by low volume kidney disease or drug use. So if the patient is taking medicine sincerely, patient is following dietary restriction, edema is not going, time to refer. Thank you. So next week will be no webinar because we have Diwali. And week after that we will meet. I have some topics which were given to me last time by speakers, by audience, and we'll take that on. Thank you very much.